So here's, I'll go back to this slide. The wealthy it's 200,000, not 250,000 joint filers, and I've gone through this already. So we have 671,000, and 1 out of every 4 people in our state are in Medicaid. That gives you a sense of the importance of this to us. Okay, now I'll get rolling back to where I was. Look at this slide. I use this for all kinds of things, but think of it as a filter for where we're at with this new law. And you say, you know, if you have a vision, a consensus, skills, incentives, everything, you can make it happen. If you don't have a clear vision, you know, you get confusion at the right hand. Where the hell are we going? If you don't have a consensus, you get sabotage. If you don't have skill set, man, I don't know how we're going to do this. You get anxiety. If you don't have the incentives aligned, you get resistance. If you don't have the money, like in the budget, you get frustration. If you don't have an action plan, you get treadmill. So think about where we're at in the debate right now and the vision itself. Can anybody, what's the vision? Repeal this sucker, right? That's the vision. Toward what end? Has any of the Republican plans declared how many insured they want when it's all said and done? I don't think so. They said they want it cheaper. How much cheaper? How to measure that? And they want better care. How measure it? So you're working after a vision right now that is get rid of this Obamacare as we know it, and it's not painting a picture for where you are headed. And so when you don't have you got confusion, and now you've got everybody's interpretation of where this ought to go, and you're starting to get the sabotage from the Freedom Caucus or from those that feel like they're going to be impacted. So you don't have these boxes aligned so if you can nail these things down, you could get, if we had a really clear vision, yeah, you know, we really are committed to ensuring 90% of the population. Let's just talk about how we're going to get there, but you don't even have that. You just have, let's get rid of Obamacare. And this is one of the real problems because they can't get up and explain what it is they're trying to do other than, you know what, it's going to be cheaper and better, right? So let's go back to Obamacare, where it started. There was a clear vision. It was going to be 34 million more insured. Now we're more like at 22 out of the 34 for a variety of reasons. But CBO scored that and said we're going to get 34 million more people out of this insured, and that's what we need to be measured against. There's also a reduction in costs. I'm going to show that and what the goal was that's being tracked for Obamacare and improved care. So there was, you know, a vision. Maybe not every, and I think actually some of it was relatively easy to agree on. How you get there is another thing. So what's happened? The uninsured has dropped down to 10.8%, not all the way down to more like 5%. Remember, the undocumented, they were not ever going to be insured, so there was a portion of the population. So there's still a ways to go, but definitely a significant, and this is what everybody says, let's not go backwards. We're the only developed country in the entire world that doesn't have national coverage for health insurance. Do you really want to go back to only 85%? What is the goal for the Republicans? I say, well, you want to have a choice. You can do an iPhone or you know, pay your premium. But that's the danger. That's the kind of, and the lack of a vision, that's the problem that we're having. So this one is hard to read, but it's very important. And you can find it from the Congressional Budget Office. When they scored, this famous CBO scoring, when they scored the Accountable Care Act, it actually reduced the federal deficit. And what it did was it expanded Medicaid and put subsidies on the exchange, and they paid for that with about $1 trillion of a combination of these taxes that you hear about on the, you know, that I just relayed, device tax, and about half of it on reductions in payments to Medicare, primarily to hospitals and health plans. So they had a way that, in fact, that middle black line there in the middle there shows that over time it actually reduces the federal deficit. And so how we've done, actually Medicare has done much better than what was in those original projections. The rate of increase has been significantly lower than what was projected. So it actually has done very well in terms of CBO scoring, in terms of the cost to the federal government. And then people say, well, Obamacare has screwed up my employer-based insurance. It's skyrocketing. Not true. If you look at what's going on in employer-based insurance, it's kind of a historical lows in terms of premium increases per year. This shows in the last 3-4 years it's been about 4% on average for employer-based insurance premium increases. So you hear about 25% increases, 50% increases. I'll get to that. That only relates to the exchanges, those 11 million people that are in the exchanges, and you'll see that only 15% of those people are paying those increases. So this talk that you have huge increases in health insurance premium is not true for the employer-based insurance. It doesn't mean there aren't some employers that have had big increases, but it's not true in balance. So this one I won't spend too much time on. But if those of you that are familiar with business models that move from one to another, and in the short run you lose a lot of business, like newspapers that went online and there was no money to pay for it, and there's subscriptions, they're still making money off of it, or Blockbuster and Netflix, and suddenly if you don't move to the blue line, eventually you're going to close up shop like Blockbuster did. But if you move too early, you might give up a lot of revenue. So in the hospital world, as we try to work on readmissions aggressively, you're giving up revenue because you're not getting admissions. But at some point, you're going to have to get into that game, right? So this effort and the incentives, and it's even part of this MACRA legislation that was bipartisan, passed last year, has kind of cemented a pathway towards this pay for value, and it's reflected in the options for physician groups to go to something called MIPS versus advanced alternative payment models. And so if you go on this blue line, you start taking on risk for the financial risk for serving a population of patients. If you stay on the red line, you get incentivized up and down, but you're basically still in the fee-for-service world. I put this up, it's a whole lecture in itself, but this movement, this fundamental change in how we're going to deliver and organize ourselves is embedded in where we're going and will not be impacted by the new law. So we've fallen short because it's too complicated, too cumbersome. Only 31 of the 50 states opted for Medicaid expansion. The reason we're not at 34 million instead of like 22 million that are now have insurance, about half of it is due to about 5 million more would be on Medicaid if those states that had elected to go for expansion had gone forward and done it. And then we're short on the individual market as well. So now, this is where you guys are smart, you'll follow this. So you hear this talk about these huge increases on the exchanges, right? 150% in Arizona and stuff. So these are this is an example, a 40-year-old non-smoking makes $30,000 on the exchange, okay? So before the tax credits, in 2016 they were looking at, in Arizona, $207 a month, right? To say, okay, I'm gonna go on the exchange. And then it went up the following year to 507, and that's what's got everybody's attention. Oh my God, look at these increases. And by the way, these are not lower than what CBO higher than what CBO originally. The year increase is huge, but they still are sitting under what CBO originally projected. But guess what? If you get the tax credits, and 85% of those 12 million people get the credits, look at what happened from 2016 to 2017. Nothing. No increases at all. So take those 12 million people, there was only 15% or about a little over 1.5 million people that actually were paying for these astronomical increases on the exchange. 1.5 million out of 300 million plus, and you'd think that the whole world is paying high premium increases. But these tax credits, subsidies on the exchanges, offset, because if you're below 400% of the federal poverty level, which 85% of the people on the exchanges are, you get these credits. Does that make sense? It's a really important point, because you hear it as if the whole insurance market, this is really small percentage of the people that are incurring this. There are actually some states that actually, see, Indiana actually went down in terms of theirs. Okay, this is not as dramatic as it really should show, but Gallup tracks, the popularity of Obamacare, and for the first time in the last couple of months, suddenly people like it. And they do this weekly, and it's widening. Suddenly, so now I understand what I got compared to what I might be giving up. So if you look at the history of this, and it can go back years too. I just took the last few months. Suddenly that right hand says, guess what? We're moving ahead. Okay, but these newly insured say, I like this exchange thing, but there are premiums, the co-pays, deductibles, there are limited networks, choice, no question. There are problems with these exchanges, and it still is not cheap, even if you get those subsidies. Medicaid, suddenly, it's great. It saved my life. You're not having the copay. You have comprehensive benefits. Suddenly, Medicaid is a pretty popular program, and there are 2.5 million people with opiate issues that are getting, covered and issues addressed that they never were before. So suddenly Medicaid has become quite a popular, and by the way, it's not cheap in the sense of, sure, if you cover more people in Medicaid, it costs more dollars, but it's cheap rates. They don't pay us much, right? The per capita costs are pretty low for covering the Medicaid population. And it's bigger than some realize. After over half people are connected to Medicaid in some way or another. They've had it, a family member has had it, and there are only 44% that are not. So, this is not something that, half of all babies in this country are Medicaid. Half. So it's no small program. And look at this, 2/3 of the people in the country basically say, we ought to keep this thing pretty much going on the path it's been. So as an example of despite the Republican Congress, they're swimming upstream against the public, feeling about the value of Medicaid. So the new health care law, you've heard this 1,000 times, pre-existing conditions, and under 26, you no longer mandated to have coverage as an individual or as an employer. You've got these age-based. I'm going to go through some of these. The support, the Medicaid expansion is eliminated in 2020. That's a big deal. All these expansion states are going to get creamed. And you move to these per capita caps. And importantly, this standard benefit package, which is pretty comprehensive, it continues in the individual market, but actually for Medicaid starting in 2020, states can do whatever they want with the benefits for Medicaid. So they can, and will probably have to shrink back the range of benefits significantly to live under the new financial constraints. So that's a big deal, and you can read the rest of these here. Does this get us, now go back to that slide I showed on vision and all the rest. Okay, are more people going to be, the test should be, are more people going to be covered? And virtually nobody says more people are going to have insurance. And the CBO, I'm sure, will say, fewer people, so is that what we want for national health policy? Fewer people insured, because that's where this is headed. Are lower costs? Well, potentially for government, especially for Medicaid. Is there anything in here, did anybody believe that, we're going to have these for-profit insurance companies now competing across state lines and the rates are going to go dramatically lower? It's conjecture, right? And not very. We've had competition in the private market among insurers for years, right? Is it going to be improved care? Not much focus. I didn't see anything on quality to speak of in the law. So it doesn't really pass a vision test or leave you with something that feels very optimistic. So this is did you read the New York Times? This shows what happens when you replace now. What happens? You saw those big, huge subsidies on the exchanges, those tax credits, right? And those were based on your health, but they're also based on your income. right? And now they're moving in and they're getting rid of all of those subsidies on the exchanges, and they're saying, we're going to give you a tax credit to go out and purchase insurance, and we're going to base it not on your income, but on your age, right? So it doesn't matter if you're poor anymore. You're not going to get any more help than if you are rich. And so what this shows is this is the wrong title, but I think it's got the wrong title on here. But it shows a shift of the winners on the right-hand side and the losers on the left-hand side. In other words, the purple are people that are going to be worse off, and the greens are the people that are going to be better off when you replace the subsidies with the tax credits, right? I better not cut off here. Oh. So you can see if you have $75,000 in income or more, or on the right side, hey, yahoo, I'm suddenly going to get new money. And if you're poor and you're older, you're going to be, those credits that you got before are going away or dramatically changed. So here's another way to look at it too. If you look at the lower income, $20,000 people on the left, the middle income, $40,000, $75,000 on the right, the blue line shows the amount of subsidy they're getting today when they're on the exchange. So you can see in Mobile, Alabama, for example, $5,700 is what you would get when you were purchasing credit towards when you're purchasing off the exchange. Now you'd get $3,000 because it'd be based solely on your age and across. And it wouldn't matter what market and community you're in, you get $3,000 in that case. For the middle income, you can see there, and for higher income that get nothing now would suddenly get a $3,000 tax credit to go purchase insurance. So you see this huge shift of wealth. Another way to show this is that the subsidies that I showed you on the exchange now that help buy and minimize those increases are in the blue lines, and the orange is what the new tax credits would be. So you can see it's funded fundamentally at a lower level, so that it's not just that it's shifting from the poor to the rich, but the overall funding and support for buying premiums is going to be about half of what it is today. So somebody's got to, and so now if you're poor and you're $20,000, you're only getting the $3,000, and you might have been getting $7,000 before, you got big trouble. So this was shown as one example. So if you're a 60-year-old, IHA showed this, and you're making $20,000 in Cook County, today you'd get $7,700 towards your purchase of the insurance, and under the new rules you'd only get $4,000, so you'd be left with this $37,000 or so $3,700 increase. And on top of that, there is these cost-sharing reductions. In other words, your co-pays and deductibles are also helped out, and that goes away in 2020. So health insurance is expensive regardless of what you're talking about. This kind of puts that credit in perspective. So admittedly, this is for a family coverage for employers. So this shows that in 2016, it's about $18,000. So you can imagine if you get a tax credit much less than that, how the heck are you going to afford the kind of insurance that you need? Okay, now let's go to the Medicaid per capita. So that's kind of the insurance market. You get the subsidies replaced with the tax credits, and now you go to Medicaid, and this is the big deal. So Medicaid now pays us in a very complicated way, but we've gotten paid for this expansion of Medicaid in a big way. And now they say they're going to put us on a budget and on a diet. So starting in 2020, they will give us a fixed amount per enrollee, and then they will let that go up hardly at all over time. And so that we can, in exchange for that, design our plans as we want, create new eligibility rules, change our benefits. But this is what is going to basically be the big challenge for Illinois. So if you look at how they do this and they say, okay, we're going to start with what we're paying you now. And there are a lot of reasons why Illinois is low. not the least of which is we as hospitals, and doctors don't get paid much in this state. But look at the difference in Medicaid spending per capita now, okay? This is a blend of what they paid disabled and adults and kids and so forth. So they take, in 2016, they sit there and they take that amount and they say, we'll give you healthcare inflation added to that up to 2020, and then we're going to give you one check based on the number of enrollees in your state times this number. So you can see how Illinois is at a significant disadvantage in terms of how this per capita spending would work. And on top of it, what is even more challenging is that for the expanded enrollment that we've had, the 671,000, the federal government has been picking up the full tab, or 95% of it. That no longer will exist after 2020. It starts phasing out, and we only get the 60% roughly match from the federal government through this per capita spending. So we get a double whammy. But the bottom line of this is, if you look at what the plan does, it's basically saying we're going to balance the healthcare budget on the backs of Medicaid. That's what, if the CBO comes out and says this law is going to be budget neutral, it's because of this. They're going to have the per capita spending, discontinue funding the expansion states, and move the financial risk to the states, so that you see over here $370 billion of what would have been paid by the federal government had Medicaid continued as it is. They're going to say, it's on you now, the states, but I'm going to let you run your Medicaid program any way you want. So you can change eligibility, you can change the benefits. This is, you know, the block, it's like the block grant concept. The only thing different in block grant is that it's a fixed amount that does not vary with the number of enrollees. It's just an overall fixed amount. So this really begins to gut. Now it says, oh, this is a chance to be innovative, you can be more efficient, etc. It just doesn't add up. So here, this shows that the government, you know, these are the GOP, the Republican governors in the expansion states, those 31 that chose to go ahead. I don't know if you can see the numbers there, but you see these are ones, the expansion states that have Republican governors. So here we are right at the top of the list with $3.9 billion. There's our 671,000 new enrollees. Let's say we've gotten about $4 billion for that. We're right up there with Ohio. That's why Kasich is sitting there saying, over my dead body am I for this law. And you've got other Republican governors is saying, if that $4 billion gets cut down in 2020 to, you know, that's going to kill my budget and locally. So who are some of the key players in this? You know these people, you've seen the names of some of them. Seema Verma, the new CMS administrator, is known for her innovation, and she has put through waivers in Indiana among the places that have kind of reinvented the Medicaid program, so to speak, and she's done it in Kentucky and others. And she's pretty smart. She's not the political player, but she knows how Medicaid programs can be revamped. The real powerhouse in this is Mulvaney, because he comes from the Freedom Caucus. He was a representative, and he is the ultimate budget hawk. And he will be delivering 1 week from, or next Tuesday or so, the federal budget. And he's the one that more than anybody probably is saying, this thing has got to be fiscally conservative. Now, there are more newcomers in all of this. I mentioned the Freedom Caucus, those kind of Tea Party right people led by Rand Paul, among others, Ted Cruz, who kind of said, this is Obamacare light, what's being proposed. They don't want any tax, basically, they don't want any tax credits. So even those skinny back subsidies, the tax credits given to people, They say that is a new entitlement program. We're not in that business. You got to get rid of the whole law, and you ought to get rid of, and particularly those tax credits, which just is an ongoing entitlement program. So suddenly the law is being pulled way to the right by the Freedom Caucus members. At the same time, they're now up to 5 Republican senators on the left that's saying, my state's going to get creamed. I expanded. You look at Arkansas, it is the sharpest decline in uninsured of any state, and it's been wildly successful. So Tom Cotton comes out this morning and said, not for us as a Republican senator. So you've got being pulled to the left, particularly the senators, and this is going to be decided in the Senate, not the House anyway, if it even makes it out of the House. It really is all about the Senate because they have to get 51 votes, and as you know, they can't afford to lose 3 people or so, or they're not going to make it. That's what it kind of comes down to more than anything else. And what happens here is what to expect. I know I've breezed through these slides, but I'm going to save some time for questions. This is going to take longer than you think, but we knew that it would, right? No matter what happens. This CBO, the Congressional Budget Office scoring, is required when you do legislation like this. So they're thinking next Monday you'll get a sense of how much this thing is going to cost. And remember, you got rid of like all of those taxes they're helping support the expansion. Those are gone. And then you've got, sure, some reductions in the subsidies, but still tax credits in there. So there's no clear picture that this thing is going to be budget neutral, although that OMB director says it will be. But you've already heard Sean Spicer say yesterday, you know what, we don't care. We don't believe it. The Obama projections, we were going to have 34 million people covered. We don't. So what good is the CBO? Even though they're an independent organization that is supposed to give thoughtful advice. So will the Republicans ignore and then Republicans? That's what happens when I do these slides at the last minute. So this budget reconciliation is an important process. So today, I don't know what's happened this morning, but there are 2 committees in the House side, Energy and Commerce and Ways and Means, that vote on this, right? And one was approved at 4:30 this morning. The other one will probably get approved too. And then it goes to the House Budget Committee next week. And then they hope to have it go to the full House this month, and then the Senate has to act. Why are they in such rush, among other things? It's because that they want to do this. This is the first of 3 phases of this repeal in place, but it's the major, really important part. And if they want to do it this year, it has to fit into this budget reconciliation process. And they want to use it this year because they only need 51 votes, not 60 votes. For some of the other changes in Obamacare, you know, it's like the mandate, the individual mandate. They actually didn't get rid of it in this legislation. They just made the penalty 0. But because you can't get rid of, with only 51 votes, you need 60 votes to get rid of certain provisions related to Obamacare. And so what they're using, but if they use the things that are just related to the budget, like Medicaid funding and all these subsidies, they can put it in the budget process and they only need 51 Senate votes. And in order to do that, the timing of budget reconciliation requires them to get this done this spring. Because next Tuesday, the budget itself is going to come out, and they have to get their act around that. So this sits inside the overall budget process, and if they can't figure out a way to get this done in that time frame, it goes away this year. It just goes away this year. So it sits in that process. And remember, their other big thing is tax reform, which is no small thing. And similarly, they want to get that done this year. So the new Republican Congress says the two big things are Obamacare and tax reform, and they have put themselves on this short leash that really requires them in the next 2 months to figure this out, or otherwise it could lapse for a long time and require the 60 votes and so forth. So that's why this timing is so important. So can the Republicans even agree? Plenty of opponents, including, you even heard the wave yesterday, AHA and AMA and AARP. Despite the Republicans saying that this was done in secret, Obamacare, there were like 150 amendments by Republicans to Obamacare. There was like 80 hearings. It went on for a whole year. Now granted, the Democrats jammed it through when all was said and done, but Obama had AHA on board, they had AMA on board, they had the pharmaceutical industry on board. They lined up industry support during that year that got us to say, we're for it. And they took the time to do that. And so the public is saying, okay, enough of those groups are feeling comfortable. That's not the case now. So this is a very different, this is enormous political capital to run roughshod over all of these groups in this time frame. And there could be a big political price of doing this. And the big question is, Obama himself kind of shepherded through those votes, and you heard Trump last night, I'm working on this. Is he really got the competencies or the attention span or the priority or the knowledge of the law Obama really knew the law to kind of really do what this, it will sap an enormous amount of his own energy, because it really is the president that would need to shepherd this through. I don't think that there is a substitute for bringing the Freedom Caucus and the senators and all those people together. And will distraction and world events sideline the process? It already has, to some extent. And is there a fallback? Administrative fixes, stabilizing the marketplaces? You can. The CMS can, and they've already begun to do things in these marketplaces that help prop up the insurers to make sure that they don't leave. And actually, if you look at Standard & Poor's did an evaluation of all this, said the markets, sure, a lot of them only have one choice right now, but they're beginning to stabilize. So don't count them out yet as an option to, remember, it's only 12 million people on those exchanges. It's not the, remember that, if nothing else. You got 12 million people on the exchange, you got 73 million in Medicaid. And so this, sure, for those 12 million people, this is really, really important, but it's a fraction of the health system compared to the reform that is quietly being hoisted or put upon Medicaid in a way that would totally change Medicaid as an entitlement program and ultimately reduce a lot of the coverage for it. It'd be interesting to see, when CBO scores this, they have to score both the finances and how many people they think would be covered over a 10-year period. So it would be interesting to see what they think the impact, because to live with those $370 billion of cuts to the states, what are states going to do? They can't just provide the same amount of care to the same number of people for the money that's going to be coming their way. Okay. There's a silver lining. I do think that finally people are kind of learning what's in Obamacare and what's in this law. And I think that in general the public is saying, you know what? Everybody, even the Republicans, they call it access to health care or access to insurance. They don't call it a right. But I think the public in general is saying, you know what? This is something that people ought to have at a reasonable price. Even the Republicans use those words, But, you know, so I do think, you know, there are election consequences. I do think we're getting closer to probably a national health policy around coverage, that we ought to be aiming for something pretty high in terms of the percentage of people that have health care coverage. I view that as a silver lining, whether it's through the town halls or other things. It's just going to be much more apparent. We've never had in this country a major entitlement program, I know, that has been taken away. And Medicaid, in effect, is being taken away, ultimately. And that is a tough thing to do. So the other elephant in the room I mentioned is that, okay, Tuesday is when they present the rest of the budget. So suddenly this will be sitting inside, you know, huge cuts in taxes, infrastructure spending, security, defense spending at 10%, no cuts to Medicare, and we're going to get a 3% increase in the GDP is what, this is all needed to do that. So you've already heard, how do you do that? When you look at the pie chart of federal spending, you see on the right-hand side, healthcare and Social Security, okay, that's kind of a given. You see other mandatory spending on the left side, that's like pension and stuff like that, that there's no choice around. So, and then you see defense going up 10% or $54 billion. So you're looking at that green kind of place as the only place to go. This is where you hear this gutting of everything in the budget that is just, you know, you got to be kidding. So this is where the rubber, you know, I said, are people really going to swallow all of this? And it'll become more apparent what's being proposed, obviously, next week. So just as a reminder of the challenges of all this, you know, for those of us that are baby boomers, you get out to 2030, you know, it's not just the funding of Medicare that is, and Social Security that is, you know, the rate itself is hard. It's just because we used to have 5 people having, you know, payroll deductions from their check, supporting one person, and pretty soon we'll only have 2. So you have to pay like 2.5 times as much to support the top. And that's the dynamic. You can get through 2030 and then out in 2050 things start getting a little bit better, but that's a ways off. So that's the challenge. And this looks at all the way back to 1930, the green line is how much money the government takes in, and the red line is how much is spent out. And you can see in 2008, that's when we went, you see back in the 40s there where we hit World War II, you know, as a percentage of the GDP, it was like 40% of all spending in the country was on government in that year, because we just said, everybody, we're going to just, you know, build up our military. So that the difference there is much greater as a percentage-wise than the aggregate dollars for sure. But you can see how we begin to close the gap since the fiscal crisis in 2008, but we're hardly there yet. So this is a real problem over time that we've got to come to grips with, otherwise we have this huge debt burden. Okay. So that was, can you pass a test on all that? I mean, it's an interesting time. You know, it's anxious, isn't it? It's just like healthcare by itself is a part of all of our lives, and it's anxiety enough, and then to have to put up with the rest of the noise, it does get a little overwhelming. I do have a lot of faith, despite what you hear in Congress, there are a lot of people that in the end do like to do the right thing. And I do think health policy will find a way to slow down. I really, if you ask me what's really going to happen, are we going to pass a real repeal and replace this spring that looks anything like what we've seen in the last 2 days? I don't think so. I just don't think that Congress there's just going to be, and if they really did that, I would see such a quick modification over time. I just can't see that playing out. But we didn't see a lot of other things.